Friends, welcome back to my channel. Today we are going to discuss neurological disorder. Before going to start neurological disorder, we have to understand the anatomy of central nervous system, because the neurological disorder is directly connected to the nervous system or central nervous system. So let's start the structure of central nervous system or nervous system. The average weight of brain is about 400 gram in men and 1250 gram in women. The skull and the vertebrae form a rigid compartment encasing the delicate brain and spinal cord. The two main divisions of the brain, the cerebrum and the cerebellum, and there are two types of tissue in the nervous system. First, neuroectodermal tissue, and another one is mesodermal tissue. So neuroectodermal tissue include neuron and neuroglia, and together form the predominant constituent of the central nervous system. And the another tissue is mesodermal tissue, are microglia, dura mater, the leptomeninges, blood vessels, and their accompanying mesenchymal cell. Neurological ectodermal tissue in first, neuron. The neuron are highly specialized cell of the body which are incapable of dividing after the first few weeks of birth. Thus, the brain damage involving the neuron irreversible. Neuron vary considerable in size and shape. Their size may range from the small granular cell of the cerebellum to large bed cell of the motor cortex. Some neurons are round, other oval or fusiform, but the prototype of cortical neuron is pyramidal in shape. A neuron consists of three main parts: the cell body, axon, and numerous dendrites. The cell body, perikaryon, is the main constituent of the neuron, from which an axon and numerous dendritic process extend. The cell body may be arranged in layer as in the cerebral cortex, or may be aggregated as in the basal ganglia. The cytoplasm contains polygonal basophilic structure called nasal substance. It consists of aggregate of RNA sheath and rough endoplasmic reticulum and intervening group of free ribosome. Neurons respond to injury in a variety of ways depending upon the etiological agent and the pathological process. These include central chromatolysis, atrophy and degeneration of neuron and axon, and intraneuronal storage of substances. Now, second part is neuroglia. The neuroglia provide supportive matrix and maintenance to the neuron. It includes three types of cell: astrocytes, and the process radiate from the cell body. Depending upon the type of process, two types of astrocytes are distinguished. Protoplasmic astrocytes have branch process and are found mostly in the gray matter. Another type of astrocyte is fibrous astrocyte, have long thin process and are present mainly in the white matter. Function of astrocyte in health are physiological and biochemical support to the neuron and interaction with capillary endothelial cell to establish blood-brain barrier. Another is oligodendrocyte. Oligodendrocytes are so named because of their short and fewer process, where when examined by light microscopy with special stain in hematoxylin eosin stain section, these cells appear as small cell with a darkly staining nucleus resembling that of a small lymphocyte. The main or major function of oligodendrocyte is formation and maintenance of myelin. Thus, in this respect, they are counterpart of swan cells of the peripheral nervous system. Disease of oligodendrocytes are therefore disorder of myelin and myelinization, such as inherited leukodystrophies and acquired demyelinating disease. Now microglia. The microglia is the nervous system counterpart of the monocyte macrophage system. The commonly used term microglia is inappropriate, since that these cells, unlike neuroglia, are not of neuroectodermal origin. Microglia cell are not fixed but are mobile cell. These are found throughout the brain and are often present close to the blood vessels. Normally, microglia cell appear as small inconspicuous cell with bean-shaped vesicular nuclei, scanty cytoplasm and long cytoplasmic process. Neutrophil is the term used for the fibril network formed by process of all the neuronal cell. Now, dura mater. The dura mater is a tough fibrous covering of the brain which is closely attached to the skull on its inner layer of endocranial peristernum. In the region of spinal canal, it encloses a potential space, the epidural space between the bone and the dura. The dura is composed of dense collagen fused with periosteum of the skull. This is the part of central nervous system. And now developmental anomalies of central nervous system. These malformations are the result of various inherited and acquired factors. The acquired conditions include viral infection of the mother and fetus, example rubella, intake of drug, example thalidomide, exposure to ionizing radiation, and fetal anoxia. These are a larger number of developmental malformation of central nervous system, but only a few important and common ones are mentioned here. So first disorder is spinal cord defect. Now spina bifida or spinal cord defect is term applied to the malformation of the vertebral column involving incomplete embryologic closure to one or more of the vertebral arcs. Most frequently in the lumbosacral region, the vertebral defect is frequently associated with defect in the neural tube structure and their covering. The bony defect may be of varying degree. The least serious form is spina bifida occulata, in which there is only vertebral defect but no abnormality of the spinal cord and its meninges. The site of bony defect is marked by a simple or a small dimple or a hairy pigment mole in the overlying skin. The larger bony defect, however, appear as a distinct cystic swelling over the affected site called spina bifida cystica. Now another disorder is hydrocephalus. Hydrocephalus is the term used for increased volume of CSF within the skull, accompanied by dilatation of the ventricle. The majority of cases of hydrocephalus, there is increased intracranial pressure. This type of hydrocephalus involving ventricular dilatation is termed internal hydrocephalus. A localized collection of CSF in the subarachnoid space is called external hydrocephalus. So, before considering the types, cause and mechanism involved the hydrocephalus, it is essential to briefly review the source and circulation of CSF. So let us know the circulation of CSF. CSF is mainly produced by choroid plaques in the lateral, third and fourth ventricle, and a small part of formed on the surface of the brain and spinal cord. The total volume of CSF is about 120 to 150 ml. CSF formed in the lateral ventricle flow through the foramina of Monroe to the third ventricle and form thereby the aqueduct of Sylvius to the fourth ventricle. Hydrocephalus is classified into two categories, primary and secondary. In primary, hydrocephalus is defined as actual increase in the volume of CSF within the skull along with elevated intracranial pressure. In secondary, hydrocephalus is much less common and is defined as compensatory increase of CSF due to loss of neural tissue without associated rise in intracranial pressure, example from cerebral atrophy and infarction. The another defect of central nervous system is infection. A large number of pathogens comprising various kinds of bacteria, fungi, virus, rickettsia and parasites can cause infection of the nervous system. So now the microorganisms may gain entry into the nervous system by following routes. First, via bloodstream, spread of infection by the arterial route from another focus is the most common mode of spread of infection in the nervous system. Another route is direct implantation. Spread of infection by direct implantation occur following skull fracture or through defect in the bony and meningeal covering of the nervous system. And the third route is local extension of infection from the contagious focus such as otitis media and frontal mastoid sinusitis may occur. Fourth route is along nerve. Certain viruses such as herpes simplex, herpes zoster and rabies spread along cranial and peripheral nerves and ascend to the CNS. The first some morphological significant lessons are: first, meningitis. Meningitis is inflammatory involvement of the meninges. Meningitis may involve the dura called patchy meningitis or the leptomeninges termed leptomeningitis. The latter is far more common and unless otherwise specified. Patchy meningitis is invariably an extension of the inflammation from chronic suppurative otitis media or from fracture of the skull. And leptomeningitis, commonly called meningitis, is usually the result of infection but infrequently chemical meningitis and carcinomatous meningitis by infiltration of the subarachnoid space by cancerous cell may occur. Infection meningitis is broadly classified into three types. First, acute pyogenic, acute lymphocytic and chronic meningitis. Another disorder is encephalitis. Parenchymal infection of brain is termed encephalitis. Encephalitis may be the result of bacteria, viral, fungal and protozoal infection. The bacterial encephalitis, bacterial infection of the brain substance, is usually secondary to involvement of the meninges rather than a primary bacterial parenchymal infection. This results in bacterial cerebritis that progress to form brain abscess. However, tuberculosis and neurocephalus are the two primary bacterial involvement of the brain parenchyma. Another defect is tuberculoma. Tuberculoma is an intracranial mass occurring secondary to dissemination of tuberculosis elsewhere in the body. Tuberculoma may be solitary or multiple. If microscopically changes are seen, there is typical tuberculous granulomatous reaction around the central cessation necrosis. A zone of gallosis generally surrounds the tuberculoma. Advanced cases may show area of calcification. Another disorder is neurocephalus. Cephalitis lesion of the CNS used to be common and serious, but more recently there is evidence of atypical neurocephalus. In a case of AIDS, the lesion in cephalus may be in the form of cephalitis meningitis found in the secondary cephalitis, and neurocephalitis consisting of taps dorsalis and generalized paralysis of the insane occurring in tertiary stage. Another encephalitis disorder is other type of encephalitis is viral encephalitis. A number of viruses can infect the CNS and produce either aseptic meningitis or viral encephalitis, but sometime combination of both term meningoencephalitis is present. Most viral infection of the CNS are the end result of preceding infection in other tissue and organ. Most of the viruses reach the nervous system by a blood stream, before which they enter the body by various routes. Example, infection of the skin and mucous membrane. In herpes simplex and herpes zoster varicella by the alimentary tract, by arthropod bite, by transplacental infection, and through body fluid in AIDS. Rabies virus travel along the peripheral nerves to reach the CNS. Pathological changes are seen, although histological changes vary from one viral infection of the CNS to the other, but in general the characteristic feature of viral disease of the CNS are parenchymal infiltrate, chiefly in perivascular location of mononuclear cell consisting of lymphocytes, plasma cell and macrophages. Macroscopic cluster of microglia cell and presence of neurophagia. Intranuclear inclusion bodies is most viral disease and specific cytoplasmic inclusion of Negri bodies in rabies. The another disorder is HIV encephalopathy or AIDS dementia complex. One major clinical feature of this entity is the occurrence of dementia. Example, fall in the cognitive ability of the individual compared to previous level. The condition is believed to be the result of direct effect of HIV on the CNS. Clinically, the disease develops in about 25% cases of AIDS, while autopsy studies reveal presence of HIV encephalopathy in 80 to 90% cases of AIDS. The histology is the changes are more in subcortical area of the brain and consist of gliose, multinucleate GN cell encephalitis and vacuolar myelopathy. The disorder is ischemic brain damage. Ischemic necrosis in the brain result from ischemia caused by considerable reduction or complete interruption of blood supply of neural tissue, which is insufficient to meet its metabolic needs. The brain requires sufficient quantities of oxygen and glucose so as to sustain its aerobic metabolism, mainly by citric acid Krebs cycle, which require oxygen. Moreover, neural tissue has limited store in energy reserve, so that cessation of continuous supply of oxygen and glucose for more than 3 to 4 minutes result in permanent damage to neuron and neurological cell. Anoxia to the brain may occur in 4 different ways. Anoxic anoxia, in which there is low inspired anemic anoxia, in which the oxygen carrying hemoglobin is reduced, and third, histotoxic anoxia, in which there is the direct toxic injury, and stagnant ischemia anoxia, in which the damage is caused by cessation of blood with resultant local accumulation of metabolite and change in pH. Pathological changes are seen. The pathologic appearance of the brain is hypoxic encephalopathy varies depending upon the duration and severity of hypoxic episode and the length of survival. Survival for a few hours. No pathologic changes are visible. Survival for 12 to 24 hours. No macroscopic changes is discriminable, but microscopic examination reveals early neuronal damage in the form of eosinophilic cytoplasm and pycnotic nuclei, a so-called red neuron, and after 2 to 7 days grossly there is focal softening. The area supplied by distal branches of the cerebral arteries suffer from the most severe ischemic damage and may develop border zone or watershed infarct in the junctional zone between the territories supplied by major arteries. Microscopically, the nervous cells died and disappear and are replaced by reactive fibrillary gliosis. There are minor variation in the distribution of neural damage to the cortex. The loss of pyramidal cell layer is more severe than that of granular cell layer, producing laminar necrosis. Another disorder is intracranial hemorrhage. Hemorrhage into the brain may be traumatic, non-traumatic or spontaneous. There are two main types of spontaneous intracranial hemorrhage. First, intracerebral hemorrhage, which is usually of hypertensive origin, and second is subbranchioid hemorrhage, which is commonly aneurysmal in origin. Pathologically, changes are seen. The hemorrhage consists of dark mass of clotted blood replacing brain parenchyma. The border of the lesion are sharply defined and have a narrow rim or of partially necrotic parenchyma. Small ring hemorrhages in the Virchow Robin space in the border zone are commonly present. Rarely, blood may rupture through the surface of the brain into the subarachnoid space. After a few weeks to months, the hematoma undergoes resolution with formation of a slit-like space called apoplectic cyst and containing yellowish fluid. Its margins are yellow-brown and contain hemisiderin-laden macrophages and a reactive zone of fibrillary astrocytosis. Another disorder is trauma to the CNS. Trauma to the CNS constitutes an important cause of death and permanent disability in the modern world. Important causes of head injury are motor vehicle accident, accidental falls, and violence. Traumatic injury to the CNS may result in three consequences which may occur in isolation or in combination. First is epidural hematoma and subdural hematoma and parenchymal brain damage. In epidural hematoma is accumulation of blood between the dura and the skull following fracture of the skull, most commonly form rupture of middle meningeal artery. The hematoma expand rapidly since accumulating blood is arterial in origin and cause compression of the dura and flattening of underlying gyri. The patient develops progressive loss of consciousness in hematoma is not drained early. In subdural hematoma is accumulation of blood between the dura and subbranchioid and develop most often from rupture of vein which cross the surface convexities of the cerebral hemisphere. Acute dural hematoma and chronic subdural hematoma. Next, parenchymal brain damage. Trauma to the CNS may result in damage to the brain parenchyma and includes the following forms: concussion, diffuse axonal injury, contusion and laceration, traumatic intracerebral hemorrhage, and brain swelling. The another disorder is myelinating disease. Demyelinating disease are an important group of neurological disorder which have in common the pathological feature of focal or patchy destruction of myelin sheath in the CNS accompanied by an inflammatory response. Demyelination may affect peripheral nervous system as well. Loss of myelin may occur in certain other conditions as well, but without in an inflammatory response. These conditions have no etiology such as genetically determined defect in the myelin metabolism, slow virus disease of oligodendrocytes, and exposure to toxins. All these entities are currently not classified as demyelinating disease. Pathophysiologically and clinically, two demyelinating diseases are distinguished: multiple or disseminated sclerosis and perivenous encephalomyelitis. The pathological changes are seen hallmark in the presence of many scattered discrete area of demyelination termed plaques. Grossly plaques appears as grey-pink solution sharply defined, usually bilaterally symmetric area in the white matter, and microscopically the features are inactive enlarging plaque. The histological features are accumulation of lymphocytes and macrophages around venules and at the plaque margin where demyelination is occurring. In addition, there is loss of oligodendrocytes and presence of reactive astrocytosis with numerous lipid-laden macrophages in the plaque. The axons in the plaque are generally intact. Other common degenerative disease are: first, Alzheimer's disease. The region which is affected is cerebral cortex, and the features is progressive senile dementia, and the predominant pathology is cortical atrophy, senile plaque, neuritis, and neurofibrillary tangle amyloid angiopathy. And another disease is Pick disease. Cerebral cortex is affected and the main feature is presenile dementia. The other disease is Huntington disease, which is affect basal ganglia and brain stem, and the main feature is progressive dementia with coriform movement, and the predominant pathology is atrophy of frontal lobes and fibrillary astrocytosis. Another disease is Parkinson disease. Basal ganglia and brain stem is damaged or affected. The main features is abnormality of posture and movement, and predominant pathology is aggregates of melanin containing nerve cell in brain stem, intracytoplasmic neural inclusion. The third is cerebral cortical degeneration. It affects spinal cord and cerebellum. The main feature is progressive cerebral ataxia, and predominant pathology is loss of Purkinje cells in cerebral cortex. And another disease is motor neuron disease. Motor neuron affected. The main feature is syndromes of muscular weakness and wasting without sensory loss. And in Werning-Hoffmann disease affect motor neurons, and the clinical feature is spinal muscular atrophy in infant. Are the common degenerative disease of CNS. Another disorder is hereditary metabolic disease. The first is neuronal storage disease, characterized by storage of metabolic product in the neuron due to specific enzyme deficiency. Common example are gangliosidosis, which have example Tay-Sachs disease, or GM2 gangliosidosis, and mucopolysaccharidosis, and Gaucher disease, and Niemann-Pick disease. These conditions are: first, leukodystrophies are disease of white matter characterized by diffuse demyelination of gliosis. They are caused by deficiency of one of the enzyme required for the formation and maintenance of myelin. This is why these conditions are also called dysmyelinating disease. Common type of leukodystrophies are pseudophilic leukodystrophy, adrenoleukodystrophy, metachromatic leukodystrophy, and globoid cell leukodystrophy. Other inborn error of metabolism, example Wilson disease, glycogen storage disease, and phenylketonuria and galactosemia disease. Another disorder is acquired metabolic disease. These includes anoxic ischemic encephalopathy, hypoglycemic encephalopathy, hyperglycemic coma, acute hepatic encephalopathy, which is also known as Reye's syndrome, and chronic hepatic encephalopathy, uremic encephalopathy, encephalopathy due to electrolytes and endocrine distribution. These are the disorder of acquired metabolic disorder. And another disorder is nutritional disease, example Wernicke's encephalopathy, subacute combined degeneration of the spinal cord, vitamin B12 deficiency, folic acid deficiency, pellagra, which is caused by niacin deficiency, and alcoholic cerebral degeneration. Now another disorder is tumor of the CNS. So tumor of the CNS, central nervous system, may originate in the brain or spinal cord, primary tumor, or may spread from another primary site of cancer, metastasis tumor. More than 1/4 of the CNS tumor are secondary metastasis arising in patient undergoing treatment for systemic cancer. In primary CNS tumor or intracranial tumor include tumor arising from constituent cell of the brain and form the supporting tissue. In childhood, tumor arising from more primitive cells, example neuroblastoma and medulloblastoma. A classification of intracranial tumor abbreviated from the WHO classified is first gliomas. The term gliomas is used for all tumor arising from neuroglia, or more precisely from neuroectodermal epithelial tissue. Gliomas are the most common of the primary CNS tumor and collectively account for 40% of the intracranial tumors. They include tumors arising from astrocytes, from oligodendrocytes, and from ependyma, and form choroid plexus. Gliomas may be well differentiated or poorly differentiated. However, gliomas are never truly well demarcated or encapsulated, and thus all grade of gliomas infiltrate the adjacent brain tissue. Gliomas are disseminated to other part of the CNS by CSF, but they rarely ever metastasis beyond the CNS. The another type of tumor is tumor of neuron, which in this neuroblastoma, ganglioneuroblastoma, and ganglioneuroma type of tumor are included. And the other type of tumor is neuron and neuroglia tumor, which is included ganglioglioma. Tumors of meninges, meningioma, and meningeal sarcoma. Nerve sheath tumor is schwannoma, and neurofibroma and malignant nerve sheath tumor. Tumor of blood cell is hemangioblastoma and lymphoma. Miscellaneous tumor is craniopharyngioma and pineal cell tumor, pituitary tumor, tumor like lesion. The drug which are used for autonomic nervous system is catecholamines. First drug is epinephrine. Mode of action is increase the rate and force of contraction and cardiac output. Second mode of action is adrenaline, stimulates adenyl cyclase and increase 3 to 5 cyclic AMP, which causes bronchodilation. And another action is cause contraction of radial muscles of iris, causing pupillary dilatation. And fourth action is constriction blood vessels and control local bleeding. And the side effect of this epinephrine is pallor, palpitation, tremors, anxiety, headaches, anginal pains, and erythemias in patient with infraction, sudden hypertension. And uses of this drug is anaphylactic shock, cardiac resuscitation, bronchial asthma, control of hemorrhage like epistaxis following tooth extraction with local anesthetic, reduce its systemic absorption, prolongs its action and reduce systemic side effect, and open angle glaucoma. Other is non-epinephrine cause action is causes vasoconstriction and thus raises BP, and the side effect is similar to the epinephrine and uses in shock. Third drug is isoproterenol. Action is it act on beta receptor but has very little action on alpha receptor, relaxes smooth muscles of GIT bronchi by stimulating adenyl cyclase and increasing 3-5 cyclic AMP. And third action is diastolic BP fall but due to increased venous return and positive inotropic and chronotropic effect, cardiac output in increased. Side effect is palpitation, tachycardia, tremor, anxiety, headache, angina, arrhythmia. And the side uses is status asthmaticus, AV block, stroke, Adams, cardiogenic shock, reverse drug. Another drug is ephedrine. Action, it stimulates cyclic EMP formation which cause bronchodilation. Ephedrine is a less potent vasopressor agent than noradrenaline, but vasopressor response persists for a longer time, and the side effect is similar to the adrenaline. And use in bronchial asthma, hypotension, nasal decongestants, stalk edema syndrome, CNS stimulant in necrolepsy and nocturnal. Fifth drug is amphetamine. It increases mental and physical activity, elation, euphoria, tremors and confusion due to stimulation of reticular activating center. It acts on the lateral feeding center of the hypothalamus and reduce appetite. The side effect is anxiety, confusion, psychosis, habituation, dry mouth, anorexia, nausea, vomiting, diarrhea. And the uses are used in obesity, temporal lobe epilepsy and narcolepsy. Sixth drug is phentermine, beta receptor stimulant, increase BP by augmenting cardiac output, and the side effect is similar to the adrenaline and uses as a vasopressor, nasal decongestant. Another is alpha agent and beta blockers. Drugs are used for autonomic nervous system. Another type of drug which is used is cholinergic and anticholinergic agent. First drug is carbachol, atropine, propanthelin and homatropine. The examination of neurological disorder. How the examination is done by the physician for the neurological disorder diagnosis. First is on history basis like motor symptoms, nutrition, coordination, involuntary movement, sensory symptoms, and cranial nerve function, higher function, and general examination. In general examination, build, nutrition, nails, conjunctiva, pallor, clubbing, cyanosis, and lymphoadenopathy, edema of feet, and BP, spine, skin, pigmentation, like patient is hyper or hyperpigmented, thickening of nerve. And the central nervous system examination is done by higher functioning like consciousness, behavior, intelligence, memory, hallucination, speech, dilution, orientation in time, place, and person. And second type of examination is done in central nervous system is cranial nerve for sense, vision, and system, and sensory system reflexes. Miscellaneous skull and spine joint including rhombus sign is done in central nervous system examination. And the other relevant examination of other system is CVS. In CVS, valvular heart disease, heart sound, and blood pressure. For hypertension, peripheral pulsation including carotid pulsation, and bruits over carotid and eyeballs are examined. SAS, hepatosplenomegaly, and ascites are diagnosed. In RS examination, chest expansion, dullness, and breath sound, foreign sound, and vocal resonance are examined. This is all about neurological disorder and their examination and drugs used in autonomous nervous system disorder. Thanks for watching my channel. If you like the information, then please subscribe and share my lecture.